Hey everyone. I'm Mohammed Hamama, and welcome back to your ASCP preparation camp. Today, we're wrapping up our series on the crucial role of tumor markers in managing specific types of cancer. In this final episode, we'll dive into essential insights on prostate cancer, testicular cancer, thyroid cancer, and cancers of unknown primary. These topics are critical for your understanding and exam preparation, so make sure you're subscribed, hit that notification bell, and give this video a thumbs up if you find it helpful. Also, don't forget to check out our store. Your support helps us continue bringing you valuable content, and you can grab some stylish gear while you're at it. Prostate cancer is one of the most commonly diagnosed cancers in men, particularly those aged between 65 and 74. Yet, despite its prevalence, it's a disease with many layers, some of which remain misunderstood. In the United States, it accounts for 13.3% of all new cancer cases, but interestingly, it contributes to only 4.7% of all cancer-related deaths. This is because many men with prostate cancer die with the disease rather than because of it. A significant challenge in managing prostate cancer is developing reliable, non-invasive methods to differentiate between aggressive cancers and those that are indolent or slow-growing. Symptoms of prostate cancer. Recognizing the symptoms of prostate cancer can be difficult, as they often overlap with conditions like benign prostatic hyperplasia, BPH. Symptoms can include frequent urination, urgency, nocturia, meaning frequent urination at night, dysuria, or painful urination, and acute urinary retention. Prostatic enlargement, back pain, unexplained weight loss, and anemia are also possible symptoms. Survival rates. Survival rates for prostate cancer are generally favorable, especially when the disease is caught early. Overall, 98.9% of patients survive for at least 5 years. For those with localized disease, the 5-year relative survival rate is 100%. However, for patients with distant metastases, meaning the cancer has spread to other parts of the body, the 5-year relative survival rate drops significantly to 28.2%. Treatment options. Treatment for prostate cancer varies based on the stage and aggressiveness of the disease. Options include curative surgery, such as prostatectomy, as well as brachytherapy and radiotherapy. In some cases, active surveillance, or monitoring the cancer without immediate intervention, may be recommended. Endocrine therapy, which involves suppressing testosterone with antiandrogens like Zollicard, is another option, particularly for advanced stages of the disease. PSA testing and measurement. The PSA, or prostate-specific antigen, is a crucial tool in the detection and monitoring of prostate cancer. However, it's important to note that PSA is not cancer-specific. Elevated levels can also occur in men with benign prostatic hyperplasia, BPH, or urinary tract infections, which makes PSA a useful but imperfect marker. For a definitive diagnosis of malignancy, a prostatic biopsy is necessary. PSA testing involves several measurements, including total PSA, free PSA, percent free PSA, and PSA velocity, which tracks the rate of change of PSA levels over time. These different measurements can provide valuable insights into the presence and progression of prostate cancer. PSA in diagnosis, prognosis, and monitoring. Men showing symptoms suggestive of prostate cancer should undergo both a PSA test and a digital rectal exam, DRE. However, a normal PSA result does not necessarily rule out prostate disease, and an elevated PSA does not always mean cancer. Additional tests, like percent free PSA, might be used before deciding on a biopsy. For prognosis, pretreatment PSA levels can help predict the likelihood of cancer spreading beyond the prostate. During monitoring, a major use of PSA is in evaluating the effectiveness of treatment. Sustained increases in PSA levels often indicate disease progression or recurrence, while PSA doubling time can provide insights into how quickly the disease might progress. Controversies in PSA screening. The use of PSA screening is highly controversial. The primary issue is its inability to distinguish between aggressive prostate cancers and those that are slow-growing, leading to the risk of overdiagnosis and overtreatment. As a result, men who are asymptomatic but considering PSA testing should be fully informed of both the potential risks and benefits before undergoing the test. Testicular cancer might not be the most talked about cancer, but it's essential to understand, especially because it's one of the most common cancers in young men. Types of testicular cancer. Testicular cancer primarily falls into three main categories, with the most common being germ cell tumors. These tumors make up over 90% of testicular cancer cases in adults, and they're generally the type most people are referring to when they talk about testicular cancer. Less commonly, there are Leydig cell tumors and Sertoli cell tumors. Leydig cell tumors develop in the stroma, the hormone-producing tissue of the testicles. These account for about 4% of adult testicular tumors but are more common in children, representing about 20% of testicular tumors in this age group. Sertoli cell tumors are similar to Leydig cell tumors and also develop in the stroma. Characteristics of Leydig cell tumors. Let's take a closer look at Leydig cell tumors. These tumors are known for their hormone production, typically producing androgens, the hormones responsible for male characteristics. Fortunately, Leydig cell tumors usually don't spread beyond the testicle, and in most cases, they can be effectively cured through surgical removal. However, if a Leydig cell tumor does spread, it presents a significant treatment challenge. These tumors are generally resistant to both chemotherapy and radiation, which limits the options for managing advanced disease. Characteristics of Sertoli cell tumors. Sertoli cell tumors share many similarities with Leydig cell tumors. Like Leydig cell tumors, they are also typically confined to the testicles and can be challenging to treat if they spread beyond this area. The resistance of these tumors to conventional treatments like chemotherapy and radiation makes early detection and surgical intervention critical. Tumor markers. When it comes to diagnosing and monitoring Leydig and Sertoli cell tumors, inhibin is the marker of choice. Thyroid cancer might not be as well known as other cancers, but it's a significant health concern, especially for women. Thyroid cancer accounts for 2 to 4% of all cancers, and it's more common in women than in men. There are 4 main types of thyroid cancer: papillary, follicular, anaplastic, and medullary thyroid carcinoma, MTC. Often, the first sign of thyroid cancer is a painless lump in the neck, which prompts further investigation and diagnosis. Tumor markers for thyroid cancer. Tumor markers play a crucial role in diagnosing and monitoring thyroid cancer. Thyroglobulin is a protein produced by thyroid cells and is particularly useful in monitoring papillary and follicular thyroid cancers after treatment. Calcitonin is a hormone produced by the C cells of the thyroid and is used to diagnose and monitor medullary thyroid carcinoma, MTC. CEA, carcinoembryonic antigen, is another protein produced by MTC cells and is valuable for assessing the tumor burden in patients with this type of cancer. Papillary and follicular thyroid cancer. For patients with papillary or follicular thyroid cancer, thyroglobulin is a key marker used in the ongoing monitoring process after treatment, which typically involves surgery and/or radioiodine therapy. To minimize the risk of stimulating any remaining cancer cells, TSH suppression therapy is often employed. Thyroglobulin measurement is critical for detecting recurrence, with a rising level potentially indicating that the cancer has returned. Medullary thyroid carcinoma, MTC. In the case of medullary thyroid carcinoma, MTC, both calcitonin and CEA are essential for diagnosis and monitoring. Calcitonin helps in diagnosing MTC and tracking the disease, while CEA is used to monitor the tumor burden. For those with a family history of MTC, germline testing can identify hereditary forms of the disease, often associated with a condition called multiple endocrine neoplasia, MEN2B. In some cases, especially in children with a family history of MTC, a prophylactic thyroidectomy may be recommended to prevent the cancer from developing. Monitoring and prognosis. When it comes to monitoring and prognosis, thyroglobulin is not useful for screening or initial diagnosis but is valuable in monitoring patients with papillary or follicular thyroid cancer after treatment. Calcitonin is crucial for diagnosing conditions like C-cell hyperplasia and MTC. CEA is particularly useful in tracking tumor burden in MTC patients. Analytical and reporting requirements. One important consideration in measuring thyroglobulin is that the results can be affected by antithyroglobulin autoantibodies, which may cause falsely low or high readings. Therefore, it's vital that any reports on thyroglobulin levels include appropriate cautions to ensure accurate interpretation of the results. What is cancer of unknown primary? Cancer of unknown primary occurs when cancerous cells are found in one or more metastatic sites, but despite thorough investigations, the primary site where the cancer originated cannot be identified. This condition accounts for approximately 2 to 3% of all new cancer diagnoses, with around 31,000 cases diagnosed annually in the United States alone. CUP presents unique challenges for both patients and healthcare providers because treatment strategies often depend on knowing the cancer's origin. Without this information, selecting the most effective therapy becomes significantly more complicated. Symptoms of cancer of unknown primary. The symptoms of CUP vary widely and largely depend on where the metastatic cancer has spread. Some common symptoms include swollen lymph nodes, often painless enlargements that may occur in the neck, armpits, or groin. Abdominal mass, a noticeable swelling or lump in the abdomen. Shortness of breath, difficulty breathing, which may indicate lung involvement. Pain in the chest or abdomen, persistent discomfort that shouldn't be ignored. Bone pain, indicative of metastases to the skeletal system. Skin tumors, unusual lumps or lesions on the skin. Anemia, low red blood cell count leading to fatigue and weakness. Weakness and fatigue, general feelings of tiredness not relieved by rest. Poor appetite and weight loss, unintentional and significant loss of weight. These symptoms are nonspecific and can be associated with various other conditions, which adds to the complexity of diagnosing CUP. Survival time. Unfortunately, the prognosis for CUP is generally poor, primarily due to the advanced stage at which it's usually diagnosed and the difficulty in identifying the primary cancer source. The average survival time after diagnosis is about 9 to 12 months. However, it's important to note that survival can vary based on factors like the locations and extent of metastases, the patient's overall health, and how well the cancer responds to treatment. Diagnosis and treatment. Diagnosing CUP is a challenging and often frustrating process. Routine clinical investigations, including imaging studies and biopsies, are conducted to try and locate the primary tumor, but these efforts are frequently unproductive. Without knowing the origin, creating an effective treatment plan becomes difficult. Treatment approaches typically involve broad-spectrum chemotherapy, radiation therapy, and sometimes surgery, aiming to control the disease and alleviate symptoms. In some cases, tumor marker measurements can provide crucial clues, helping to identify an unsuspected but potentially treatable malignancy in a small subset of patients. Tumor markers used in cancer of unknown primary. Key tumor markers used in CUP include AFP, alpha-fetoprotein, and HCG, human chorionic gonadotropin, recommended for patients with midline metastatic disease to assess the possibility of a germ cell tumor. CA-125, suggested for women exhibiting symptoms consistent with an occult non-germ cell ovarian malignancy. PSA, prostate-specific antigen, advised for men presenting with bone metastases or multiple sites of involvement, to evaluate for prostate cancer. Chromogranin A, utilized when features of neuroendocrine tumors are present. Estrogen and progesterone receptors, testing these can help identify hormone-sensitive tumors that may respond to specific therapies. CA-19-9, recommended for patients with suspected pancreatic malignancy. Identifying these markers can guide clinicians toward more targeted and effective treatments, even when the primary cancer site remains unknown. Thank you for watching. If you found this video helpful, share it with friends who might benefit from it. If you have any questions or comments, feel free to drop them below. I'm always here to help. And don't forget to ask for our ASCP short notes to boost your exam prep. Make sure to hit that subscribe button so you never miss our next dive into the fascinating world of science. Lastly, be sure to check out our store. Your support means the world to us. See you in the next video.